reports from patients for me that link so visually to this. The one is a patient who had a bilateral left reconstruction. She went for a flight in a Tiger Moth aeroplane, which is a small aeroplane, and it's almost a fabric. It's made out of fabric. She could not get out. Once she was seated, she could not push herself out of that position because she felt that the material was too flimsy. She couldn't push on it, but she could physically not exert the force she needed to push herself out of it. So that's exactly what we're seeing there. Your arms will be forward because you're sitting in a small space, and to from there lift yourself up, forced extension, trying to come up. She wasn't able to. Another patient would say that if she sits on the floor with her grandchildren, to stand up and push herself off the carpet, she's unable to do that. Last in from the USA, they evaluated patient satisfaction and function. They had an average follow-up of 1 year and 8 months, and the patients were doing well, but 25% of patients had complaints. Almost 2 years after surgery, 27% of patients had continued to have a decreased muscle strength. 22% of patients continued to have a loss of range of movement. 25% of patients had pain. And it needs to be noted here that 3 of the participants still had significant pain. Almost 2 years after surgery, still have to have significant pain. That was something that stood out for me. I just think that the prospective studies still don't ask the right questions, especially if you're going to use a single tool evaluation. It lacks depth and it lacks spectrum to really analyze and interpret the results if you only have a single assessment tool. There's not enough that looks at the biomechanical changes that occur in the shoulder. We don't see a link between loss of power, which is well described, muscle strength, but what is the effect of that on the rate of fatigue? So it's all fair to ask a patient to repeat the movement once and then they do okay, but if they have to continuously do that, what is the effect then? That becomes function. So the plan is not just to stick to what we know now. The plan is to actually go back and do research. Actually, it would have to be retrospective, but go and find the patients who've had the procedure, and on top of doing very specific functional evaluations, looking at fatigue proximally, but then almost to move more to a fascial adhesion assessment, to find out where patients continue to have tender points in places where they don't expect to have tender points because it's not close to the surgical scar. But the moment you remove the latissimus dorsi, it leaves a scar all around the border of it. And that's why that visual image of what a big muscle it is important, because all along the edges of it, you're going to have adhesions that cause tender points and discomfort. But yes, to then go and look at what areas we see scarring and adhesions that cause problems, but to actually try and focus a little bit more what's happening in the pelvic area with balance